Hi, good evening. This is Dr. Anjali Pal here. We're going to talk about papulosqamous disorders. So they mainly include psoriasis, lichen planus, pityriasis rosea, and pityriasis rubra pilaris, or PRP. So we're starting with a question. Not a histological feature of lichen planus is acanthosis, hyperkeratosis, neutrophils in stratum corneum, or pigment incontinence. Looking at the histopathology of lichen planus, right on top you can see in the epidermis there is hyperkeratosis. So the first point is epidermal hyperkeratosis. Coming down lower in the epidermis, in the stratum granulosum, so you have a hypergranulosis, that means an increase in the thickness of stratum granulosum, which is wedge-shaped. Lower down, there is sawtoothing of the rete ridges. So the rete ridges are at the interface between the epidermis and the dermis. Okay? At the basal layer, there's vacuolar degeneration seen in the keratinocytes. Individual cells would have vacuolar degeneration. These are known as civet bodies. That means individual cells get necrosed. At the dermoepidermal junction, that means between the epidermis and the dermis, there is a band-like infiltrate of lymphocytes, the bluish band which you can see. These are there, so that's in the superficial dermis. And this is called a lichenoid infiltrate. This is characteristic of lichen planus and other lichenoid skin conditions. This band-like infiltrate of lymphocytes, because they're basophilic, so it's called a lichenoid infiltrate. Incontinence of melanin is also a point in lichen planus. So that means when the lesion heals, when lichen planus heals, there are melanocytes, or melanin drops down into the dermis. So that's called incontinence of melanin. Melanocytes, as we know, are in the basal layer of the epidermis. And because of the inflammation, during the healing process, it drops down. Some melanin drops into the dermis. That's called incontinence of melanin. So taking a closer look, the uppermost arrow here shows the wedge-shaped hypergranulosis, right, like an inverted pyramid. Lower down, you can see individual basal keratinocytes are getting necrosed. Okay, so that's vacuolar degeneration. You can see a little sawtoothing of the rete ridges, and I've pointed out some lymphocytes there, the part of the lichenoid infiltrate at the dermoepidermal junction. So the answer to this question, we have acanthosis. Acanthosis means thickening of the epidermis, right? Hyperkeratosis is there. Neutrophils in stratum corneum are not seen in lichen planus. This is a feature of psoriasis. Okay, these are specifically known as Monroe's microabscesses, a collection of neutrophils in the stratum corneum. So this is the answer. And pigment incontinence is seen in lichen planus, as explained. So lichen planus is a T-cell mediated autoimmune disorder. It's characterized by 4 Ps. So they're violaceous or purple, flat-topped papules and plaques. That means elevated lesions, right? And these are classically pruritic. Lichen planus affects the skin, the mucosa, hair, and the nail as well. So on the skin, you can see these characteristic lesions. You see the flat top plaques, which are purplish, okay, and they're polygonal as well. These occur typically on the wrist flexors. They can occur on the trunk, on the shins also. Kebner phenomenon is positive. I'll talk about that in a while, okay. And there's a specific type of lichen planus. It's called lichen planus pigmentosis. In this type, there are flat patches of pigmentation. And these are not so much purple, but they're more ashy gray pigmentation. This usually covers the face and the neck. So that's one particular type of lichen planus pigmentosis. On the mucosa, you classically see Wickham's striae. This is usually seen on the buccal mucosa, and Wickham's striae is basically lacy whitish pattern on the buccal mucosa. You can also see violaceous plaques of lichen planus sometimes. Patients may have a burning sensation in the mouth. Okay, that is one symptom of oral lichen planus. In the hair, I'll show you a picture of lichen planus affecting the scalp. You will have scarring alopecia and perifollicular pigmentation classically. In the nails, you can see here, classically you have a pterygium of the nail in lichen planus. which is seen here. This is also known as pop tenting, okay, where both the parts of the nail are elevated towards the center, towards the middle. This is scalp lichen planus. So it is a scarring type of alopecia. That's important. Okay. There is central atrophy in this patch, and around in the borders you have the activity of the lesion. So you can see there is perifollicular hyperkeratosis. And if you take a closer look, when you look with a dermatoscope or a magnifying glass, you will see perifollicular pigmentation. That means pigmentation around the hair follicles, which will also be violaceous. So Kebner phenomenon is also known as isomorphic response. It's the appearance of new skin lesions of a pre-existing skin disorder on areas which are injured, okay, in otherwise healthy skin. So this is classically seen in 3 conditions: psoriasis, lichen planus, and vitiligo. So you'll see, like here, you can see the small erythematous papules seem to extend along a line. So if the person has sustained trauma, like a scratch or even some insect bites, those lesions come onto those new spots as well. So the treatment of lichen planus is simple. Divide these things into topical treatments and systemic treatments. In topical, we usually use systemic topical corticosteroids. Salicylic acid ointment also helps in lesions that are thick, that are keratotic. So sometimes we combine corticosteroid with salicylic acid ointment. Tacrolimus is a common calcineurin inhibitor, which we use topically as well. Okay, we can use that for oral lichen planus. Systemic medications can be oral retinoids like acitretin or corticosteroids, which are given usually in an extensive lichen planus or one which is spreading rapidly. So next question. Cicatrizing alopecia, that means scarring alopecia, with perifollicular blue-gray patches is most commonly associated with erythematous scaly plaques, whitish lacy lesions on buccal mucosa, arthritis, and discoid plaques on the face. So the answer would be the Wickham's striae, which they're talking about, of lichen planus. So they've described scarring alopecia in lichen planus, right? And that is associated with the buccal mucosa lesions, again, of lichen planus. Option A, erythematous scaly plaques, is typical of psoriasis. Option B, again, would indicate psoriasis because psoriasis is associated with arthritis commonly. Option D is discoid plaques on the face. This typically suggests DLE, that is discoid lupus erythematosus. Okay, so these are not the answers. In which of the following is Kebner phenomenon not seen? Lichen planus, psoriasis, lichen nitidus, or lichen simplex chronicus? So we know it's seen in lichen planus, psoriasis. Lichen nitidus is a condition in which you have follicular papules classically seen in children. You may see it on the trunk, on the elbows and knees, on the buttocks as well. There's no specific cause for why it occurs. Lichen simplex chronicus also means eczema. It's just a well-circumscribed discoid eczema. Okay, so the answer is lichen simplex chronicus because eczema does not follow a Kebner phenomenon. This is just a photo of a discoid eczema. Okay, and this is lichen nitidus, which is pinpoint papules, shiny papules. Okay, this is seen on the knees and elbows. Here. Wickham's striae is seen in lichen nitidus, lichenoid eruptions, lichen striatus, or lichen planus. This is easy. Itchy polygonal violaceous papules are seen in. The answer is clearly now lichen planus. Okay. Psoriasis, you see scaly erythematous plaques. Pemphigus is a bullous disorder. You will see flaccid blisters. Or on an erythematous base, on a reddish base, okay, there's inflammation. And in Pityriasis rosea, you will see annular scaly plaques. Psoriasis is exacerbated by lithium, beta blockers, antimalarials, or all of the above. The answer is all of the above. So psoriasis has certain factors that worsen it or exacerbate it. Okay, one most commonly it worsens in the winter. Okay, so dry, cold weather, stress, any form of stress or injury will worsen psoriasis. So that includes surgical stress as well. Beta hemolytic streptococcal infection classically tends to cause or tends to exacerbate guttate psoriasis, and this occurs usually in children or young adults. This is important. Drugs, including all the above, and corticosteroids as well will exacerbate psoriasis. So you must remember that systemic corticosteroids are never given for psoriasis except in one condition. I'll talk about that later. Smoking and alcohol also are known to worsen psoriasis. The important feature of psoriasis is crusting, scaling, oozing, or erythema. So psoriasis classically is erythematous scaly plaques. The scales are thick silvery white scales. This is the classic feature of psoriasis. The crusting is basically when there's a mixture of blood and serum that is called a crust. So a crust is seen in an eczema because it is scratched or excoriated. Okay. Oozing again can be seen in eczemas and insect bites, or in a blistering condition, a bullous disorder like pemphigus. It's classically not seen in psoriasis. Erythema is seen in most psoriatic lesions, but it is not the most important feature. Important feature is the thick, scaly, silvery white scales. So the clinical features of psoriasis, this affects the skin, the nails, the scalp, and the joints as well. On the skin, you see erythematous scaly plaques. You have annular, thick scaly plaques. Okay, the silvery scales are very important to remember. These are classically seen on the extensor aspects. Can see it on the scalp as well, usually. And Skebner phenomenon is positive in psoriasis usually. Auspitz sign is a clinical sign which is demonstrated in plaque of classical psoriasis vulgaris. So when we scrape a psoriatic plaque with a glass slide, the first thing you remove will be the loosely adherent thick waxy silver scales. The next layer is a red moist membrane known as the Bulkley's membrane. And when you scrape that, that is the dermoepidermal junction, you will reveal pinpoint bleeding. That is because of the dilated capillaries in the dermis. So this is Auspitz sign seen in psoriasis. Nail changes in psoriasis are many. So I've just shown you a diagram of all the various nail changes you can see. Most common and classical will be pitting. Okay, that is thimble pitting of psoriasis. So usually that's a uniform pitting. Okay. Onycholysis, which means the separation of the distal nail plate from the nail bed. Sphincter hemorrhages, which are seen as linear red streaks through the nail plate, and salmon patch, which is another typical psoriatic lesion. It's a pinkish colored oval patch on the nail. Other features are subungual hyperkeratosis, leukonychia, which is whitening of the nail plate, and tracheonychia, which is just destruction of all the nails. Joints are also affected. Usually these are the small joints and they can cause permanent deformities. So the types of psoriasis, the classic chronic plaque psoriasis is usually seen on extensor aspect. So on the elbows, the knees, and the scalp as well. Guttate psoriasis, guttate means raindrop pattern. So this is usually seen in children or young adults. Flexural psoriasis is inverse psoriasis. So this is seen in the flexors, that's the groin or the underarms, the arm folds. This is not so common. Scalp psoriasis, palmoplantar psoriasis can occur, and sometimes this can be pustular. So you can have palmoplantar pustulosis. Nail psoriasis, and a typical form is erythrodermic psoriasis. This means 90% or more of the body surface is covered with psoriasis. Pustular psoriasis is another separate entity. So how do we clinically evaluate psoriasis? We We use a score called the PASI score, or the Psoriasis Area and Severity Index score. This is usually done so that we can monitor improvement with treatment. Okay? So the PASI score has several factors involved. You just need to know basically, one is the percentage of body surface area involved. The second factor is erythema of the plaques, of the lesions. The third is scaling, how scaly are the lesions. And the fourth is the thickness or induration of the plaques. Now, histopathology of psoriasis. There are several classical features. This is a low power view, okay, low power magnification of a psoriatic plaque. So you can see here on top, there is a deeper purple part in the keratinized layer. So that is a subcorneal pustules. Okay, those are collection of neutrophils, okay, in the corneum, stratum corneum. You can see these long elongated retiridges, classic elongated retiridges. This is classic of psoriasis. Okay? And in the suprapapillary areas, here you can see the dilated capillaries, some dilated capillaries. You can see a lymphocytic infiltrate in the dermis, which will be perivascular usually. So this is a higher power view. You can see the collection of neutrophils, okay, in the stratum corneum, in the keratinized layer, and down here as well you can see a collection of neutrophils, which is like a pustule basically in the epidermis. So in psoriasis you will have regular acanthosis, that means thickening of the epidermis. You'll have those classical elongated retiridges, that means the part of the epidermis which drops down into the dermis, like elongated, okay, ridges, and the other part, the dermal papilla, which projects upward between these retiridges. This part above the dermal papilla is the suprapapillar part, so that is thinned out. Okay. There's parakeratosis, that means the presence of nuclei up to the stratum corneum, which is not a normal feature. So because of the multiplication, the rapid multiplication of cells in the epidermis, the nucleus which is present in the basal layer can still be found up until the stratum corneum in psoriasis, which is not normally there. You'll find collections of neutrophils in the stratum corneum like pustules. So these are known as Monro's microabscesses. And a similar collection of neutrophils, but in the stratum spinosum, is called spongiform pustules of Kogoch. There is prominent capillaries seen in the dermal papillae. So you may see some cross-section of blood vessels there, okay, dilated. Some comorbidities that are associated with psoriasis are the inflammatory arthropathy, okay, spondyloarthropathy. There's inflammatory bowel disease, Crohn's, and ulcerative colitis, metabolic syndrome, so diabetes and hypertension and cardiovascular disease is commonly associated with psoriasis, along with obesity as well, and fatty liver or NASH. So the treatment of psoriasis, we'll start with the topical treatments. In plaque psoriasis, which may be limited, we use mainly topical treatments. So the most common is corticosteroids. So clobetasol propionate would be the most common. Salicylic acid ointment is also commonly used to thin out the hyperkeratinization. We often combine the corticosteroid with the salicylic acid ointment. Vitamin A analog called tazarotene is used topically sometimes for skin lesions and also for nail lesions. Okay. Vitamin D analog is called calcipotriol or calcipotriene. These can be used for limited plaques as well. Coal tar calcineurin inhibitors like tacrolimus, dithronol, and most important, of course, emollients. Okay, this is just moisturizers and things that contain urea as well. The second is phototherapy. So narrowband UVB, that is NB-UVB, which is 311 nanometers wavelength, is typically used, okay, for psoriasis. A broadband UVB may also be used, and there's a type called PUVA, which is psoralen plus UVA therapy. Okay, it's also known as photochemotherapy because psoralen is a photosensitive chemical which can be either applied onto the plaques, it can be consumed orally, or you can bathe in a solution of that 2 hours before you expose the patient, expose yourself to UVA light. Okay, so that's photochemotherapy. Excimer laser is basically a laser which emits a wavelength of just 308 or 311 nanometer. And this is also used for just limited plaques of psoriasis. Sessions of phototherapy are usually done 2 to 3 times a week. Other conditions that improve with phototherapy are vitiligo, atopic dermatitis, some severe eczemas, and certain conditions which are light sensitive. So polymorphic light eruption can also be treated with phototherapy to sensitize the patient. Cutaneous T-cell lymphomas sometimes are also treated with phototherapy. Now, systemic medication. There are 3 main medication, okay, which are specific for psoriasis. They are methotrexate, acitretin, and cyclosporin. So methotrexate has an anti-inflammatory and an anti-proliferative action. It also works on psoriatic arthropathy. So that's an advantage. When you give it, it treats both the skin lesions and the joints. You have to remember to give folic acid along with methotrexate. It's given as a once weekly dosage, and it is contraindicated in pregnancy. Acitretin is a retinoid, and this has a few indications. You can treat pustular psoriasis with it, as well as psoriatic erythroderma, that is extensive 90% or more body surface area involvement. Retinoids are category X, they are not allowed in pregnancies, and acitretin specifically is not allowed up to a year prior to planning pregnancy as well, because it is fat soluble and it stays in the body in the fat stores. Cyclosporin it affects the T cell activation, so it's an immunomodulator, and this specifically works very fast. You can start seeing improvement within 72 hours. So it's given in cases which are very extensive or where a patient may need immediate improvement, urgent improvement. So the treatment of choice for erythrodermic psoriasis is corticosteroids, methotrexate, coal tar topical, or topical corticosteroids. Corticosteroids, oral corticosteroids are contraindicated in most cases of psoriasis. Okay, coal tar cannot usually be used to treat erythrodermic psoriasis. It is also an irritant in some cases. So when you have more than 90% body area involvement, coal tar exposing compromised skin to coal tar may actually worsen the condition. And topical corticosteroids again will not be so effective in erythrodermic psoriasis, because in this case such extensive body involvement would also lead to problems like problems involving homeostasis of the body in general. So methotrexate is the best answer. The most common association with coarse pitting of nails and onycholysis is, so pitting of nails again and onycholysis are seen in psoriasis, right? So we're looking for lesions of psoriasis. Violaceous plaques, that's in lichen planus. Well-defined scaly plaques, that suggests psoriasis. Scarring alopecia, that is more in lichen planus. Psoriasis does not cause alopecia. Polygonal papules, again, indicates lichen planus. So the answer, well-defined scaly plaques. This is psoriasis. The most characteristic finding in lichen planus is civet bodies, basal cell degeneration, thinning of the nail plate, or violaceous lesions. So civet body is the necrosis of individual keratinocytes in the basal layer, right? That's not very characteristic of just lichen planus. It can vacuolar degeneration can happen in other lichenoid conditions also. Basal cell degeneration is quite characteristic of lichen planus and lichenoid conditions as well. Thinning of the nail plate is not seen exclusively in lichen planus. Violaceous lesions indicate lichen planus but can be seen in many other conditions as well. Okay, you may have erythema multiforme which may look violaceous on dark skin type. So that's not classical. Basal cell degeneration would be the best answer in this case. Treatment of choice for acute generalized lichen planus. So we're talking about some oral treatment. So topical corticosteroid, again, difficult to apply on such a large body surface area. Systemic corticosteroids can control. Antihistaminics are just symptomatic treatment. Emollients, again, are just symptomatic improvement. So systemic corticosteroids would be the best answer here. Auspitz sign, this we know now is, so this is seen in classic plaque psoriasis. In pustular psoriasis, you don't have plaques. It's not seen in lichen planus. And inverse psoriasis, again, which is in the folds or the flexures, typically does not have scaling because of the moist nature of the skin in the flexures. So you would see this only in plaque psoriasis. The drug of choice for a pregnant woman in second trimester with pustular psoriasis is prednisolone, dapsone, acitretin, methotrexate. So here we have three drugs which are contraindicated in pregnant women. Okay, they are dapsone, acitretin, which is retinoid, category X, and methotrexate, category X. So that leaves prednisolone. This is the only indication in psoriasis where you give a corticosteroid, that is pustular psoriasis of pregnancy. It's also known as impetigo herpetiformis. Okay? It's a name which can confuse because it is neither impetigo and it is neither herpes. So this is just a misnomer. You just need to remember impetigo herpetiformis is another name for generalized pustular psoriasis in pregnancy. Pseudo-isomorphic phenomenon is seen in psoriasis, lichen planus, vitiligo, or plain warts. So we know what isomorphic phenomenon is. That is Kebner phenomenon. That's seen in psoriasis, lichen planus, and vitiligo. Pseudo-isomorphic phenomenon is seen in warts. Okay, that is where it's basically where inoculation of that lesion into in a linear fashion, that's by physical spread or by trauma. Okay, so since warts are infectious, from one wart, if there's a scratch, then there's a good chance that the wart will also get transferred onto the scratched skin. So that is called a pseudo-isomorphic phenomenon because it mimics Kebner phenomenon, but it's not really. Okay, characteristic nail finding in lichen planus is pitting, pterygium, Bose lines, or hyperpigmentation of the nail. Pitting is classical of psoriasis. Pterygium is classical of lichen planus. Bose lines are lines which indicate a particular time when a patient has gone through stress or severe illness or malnutrition. Okay, so they are lines that occur at the same distance from the nail fold, and they occur on all the nails, all 10 nails. Hyperpigmentation of the nail plate is seen in many conditions, not specific to lichen planus. The only definitive indication of systemic steroids in psoriasis, so you should know this by now, is it pustular psoriasis, is it impetigo herpetiformis, psoriatic arthropathy, or erythroderma? Impetigo herpetiformis or generalized pustular psoriasis of pregnancy. Interface dermatitis is histological feature of psoriasis, lichen planus, pityriasis rosea, or dermatophytosis. Interface dermatitis, or the lichenoid infiltrate in the superficial dermis, is seen in lichen planus. Okay. Calcipotriene is a vitamin A, B, D, or E analog. As I've told you before, it's a vitamin D analog. Okay? It's used topically in psoriasis. Christmas tree appearance on the skin is seen in pityriasis rosea, pityriasis rubra pilaris, psoriasis, or vitiligo. So it's seen in pityriasis rosea. Now, what is pityriasis rosea? This is a classical picture. So this is the back of a person in which you can see this large plaque, one single annular plaque that is called the mother patch or the herald patch. And then there is a fir tree or a Christmas tree pattern on the rest of the back of these secondary lesions. So it's caused by a virus, probably herpes, human herpes virus 6 or 7. It's classically got a fir tree distribution of lesions on the torso. It may extend to the upper thighs. The first lesion to appear is the herald patch or the medallion lesion or the mother patch. And in a few days later, you get this fir tree appearance of these secondary lesions. These are all annular. Classically, in each lesion, you will see a peripheral collarette of scales. It's a very classical sign to distinguish it from other annular lesions. So a collarette means the scale on the skin, if you look at the diagram here, the photo, is attached to the periphery of the skin, but towards the inner side of the lesion, the scale is loose. So it opens up towards the inner part of the lesion. Okay, that's a collarette of scales. And a hanging curtain sign is seen in PR. Hanging curtain sign is when you stretch the lesion perpendicular to the long axis of the lesion, you will elicit more of these fine scales. So it's like a hanging curtain. And what is PRP, or Pityriasis rubra pilaris? There are a few classical features you need to know about it. You don't need to know about it in detail. It is, there is a keratoderma of the palms and soles, also known as the PRP sandal, because there's a very thick layer of the skin, which forms on the palms and soles. This is usually a condition seen in childhood. The lesions are reddish or orange. You have to remember this orange color, okay, that's seen in PRP. And these are scaly rashes seen on the trunk, as you can see here in the second picture. And in the third picture, you can see islands of sparing of the skin. This is very classical in PRP. This rash can be quite extensive. It can even become an erythroderma. So PRP is another cause of erythroderma. The hair follicles get plugged with keratin, so the rash is quite scaly and bumpy.